Good evening, everyone. My name is Inakshi Sopthi, and I'm the Chief Executive Officer of the Asia Society India Center. A very warm welcome to all our members, speakers, and other guests who've joined us for our center's second virtual program of 2021, titled Beyond the Vaccine Public Health Systems Revival in India. Our conversation this evening is a part of our Re-Engineering Public Health Delivery in India series that aims to catalyze discussion on how we can reimagine and rebuild India's tenuous public health systems. Through this series, we will bring you insights from leading medical experts, public health practitioners, and business leaders working towards fortifying the system and striving to make quality healthcare in India accessible. Early this year, India embarked on the biggest COVID-19 vaccination drive in the world, in addition to introducing a budgetary overhaul in the healthcare sector as part of the union budget for 2021. Post some stressful months in 2020, an effective communication strategy, and a now coordinated center-state effort has resulted in a steep decrease of daily recorded cases, wider adoption of precautionary measures, and a gradual recovery of economic activities. While efforts in this direction are reason for hope, the pandemic has and should force us to reorient our focus on addressing the structural challenges faced by our public health system, bridging infrastructure gaps, and making quality healthcare a reality for all. Our conversation today will try to understand these complexities and suggest solutions that can address these issues through public-private partnership, leveraging technology, and active stakeholder involvement. We have a highly experienced and accomplished panel of speakers here this evening. Dr. Gagandeep Kang is a celebrated virologist and professor of microbiology at the Wellcome Trust Research Laboratory at the Christian Medical College at Vellore. Dr. Anupam Sibal is the Group Medical Director at Apollo Group of Hospitals and has several decades of experience in the private healthcare sector. K. Sujatha Rao is a former Union Secretary for the Ministry of Health and Family Welfare and has represented India on the boards of the World Health Organization and the Global Fund. And our moderator for this evening, Dr. Priya Balasubramaniam Kakkar, is a senior public health scientist at the Public Health Foundation of India and director of the PHFI Universal Health Initiative. A bit of housekeeping before we proceed. For all those who are joining us on Zoom, please leave your questions in the Q&A box and your comments in the chat box. For our audiences on Facebook, please share them in the comments section. And with that, I'd now like to invite Priya to commence the discussion. Thank you.
Thank you, Inakshi, for your very kind introduction. And I would like to thank the Asia Society for this very kind invitation. I'm honored to have this opportunity to facilitate this discourse on conversation on health reforms in India with this very distinguished expert panel. So welcome again, all of you all. Before I start, I just want to give a little bit of context. And I think it's a context that everybody knows. The last year, 2020, I think COVID-19 pandemic has been one of the biggest steps for modern India's healthcare system. And while it has revealed huge cracks in our public health system and its very foundations that need to be potentially rebuilt, it has also enabled in putting health at the forefront of our national discourse, especially over the last year and continuing through this year. This is something that has never happened before. Government and the private sector are working intensively right now to contain spread, deploy, as well as develop preventive vaccines and share innovations both in diagnosis and treatment. And in doing so, they've had the ability to create new ways to collaborate for public good. But yet there continues to be a lot of debate around the political economy of COVID. And it's also highlighted responses that have been extractive, regressive, and competitive. and brings to light questions around health equity, health equality, and ultimately affordability to health services. In India's current response and ongoing vaccination drive, there remains that fundamental question: will this promote greater investment and reforms within India's health systems, as well as health outcomes for the long term? Will it lead to universal health coverage? Will it lead to societal protection? And I'd like to open this conversation with this broad question to our panelists. What are some of the emerging lessons that the COVID-19 pandemic has brought about? How is this impacting health system strengthening in it? Done right, and what can we do better? I'd like to start with one of the most topical issues of the day, and I'd like to start with Dr. Kang. Right now, we are undergoing one of the biggest vaccination drives in the country. And over the past couple of months, over 16 million people have already been vaccinated. But yet there remains a lot of hesitancy over the choice and effects of various vaccines. There's also an information asymmetry around this to the general population. What kind of vaccines do we take? What is the efficacy of the vaccine? How long will it last? Should we take it? What if I have conditions like diabetes, or I'm a heart patient, or I have allergic manifestations? So in your opinion, as the national vaccine expert, and as an outspoken advocate for evidence-driven transparency, what do you think? What have we done right in terms of rolling out the vaccine? Where can we do better?
Thank you very much, Priya, for that question. And thanks to the Asia Society for having me here. I think to do this, if you don't mind, I'd like to take a couple of minutes and compare the last national rollout, which was the rotavirus vaccine. We are currently in the process of rolling out the pneumococcal vaccine, but it hasn't gone nationwide as yet. Rotavirus was the last one that went countrywide. So I was on the sidelines watching that happen, and it was something that was done in phases. It involved the government having immunization partners, and there are many organizations that help the government with its immunization effort. We started, I think, Mrs. Rao may know this better than I do, but a lot of input started to come in when we had the polio programs. And subsequent to that, we've had multiple other partners come on board. So in the case of the rotavirus vaccine, this was something where John Snow India, a branch of John Snow International, was asked to be the immunization partner. So they set up a system that was cascading training, developing the materials, making sure that the materials were fit for purpose, were reviewed, that training exercises were undertaken for the vaccinators, an education program was set up. There was concern around the fact that rotavirus vaccines might lead to interception. How would that need to be handled? What was all of the evidence? And I sat in on those trainings, and they were really well done. When do you introduce a vaccine? When you know that there is significant disease burden, when you know that the vaccine is something that works, when you know that the immunization system can handle such a vaccine, and this is something that will promote equity. Rotavirus vaccines had been in the private sector for quite a while, and then became available to the public sector from 2016 onwards. Now, I was also doing an impact assessment study at the time, and what you saw was initially there were glitches, coverage was low. But then about a year after the states had gotten their vaccine, coverage ramped up and pretty much matched what was happening with the pentavalent vaccination. And now we are in a situation where the whole country has the vaccine. It took almost 3 years, and that was pretty rapid for a countrywide rollout. It took about 3 years to get this done. So what are the differences with what we are trying to do now? I don't know who the partners are. I know that there is a lot of direction that comes from the center to the states, which then have to implement this immunization program. This is an unusual immunization program because there is a limitation on supply, and there are priority groups that are completely different from what the immunization system has handled previously. So you're going to adults, you're going to healthcare workers, you're not going to children, which is something that you know. I was very impressed with the beautiful document that the government prepared on communication strategy, until I discovered that healthcare workers don't know what is in that communication strategy. So if you have not done the kind of training that we did for rotavirus, it has not reached healthcare workers themselves, then I think these are gaps that should be looked at to see how we can do better. Because it is ultimately healthcare workers that convince the rest of the population that these are important vaccines and need to be taken. So perhaps in the fact that we have compressed so much into so little time, things have not gone exactly as they should have. We saw the practice rollouts, the dry runs that were done that identified some gaps, the COVID app not working, etc. But because we are doing everything under pressure, there are going to be problems with this kind of delivery effort. And what we should be doing is having a very rapid iterative process. What I've seen from states is that every state is handling that iteration in a slightly different way. Some are doing it really well. Some of them are struggling with that. But the fact remains, we've undertaken a very, very challenging exercise. If we take stock of where we are today, in absolute numbers, we have done very well. In terms of reaching a percentage of our population that will allow us to have the trajectory that the government had projected, which is to reach 300 million people by August, we are nowhere at the moment. So there is a lot being done, but there is also a lot for us to do.
Thank you, Dr. Kaur. A quick follow-up question. We have a plethora, almost a thali of vaccines that are being developed in India today. We have Covishield, we have Covaxin, there's Minvax, the Sputnik 5, and then there are, there's a whole range of vaccines. We are also vaccinating right now the first, in this first phase, healthcare workers, providers, as the first cohort to be vaccinated. The next in line are elders, and there is a huge proportion of elders in this country. And there is a lot of questions around, is it safe to get my mother vaccinated today? What would your answer be? Is this something that we should go ahead with? Is it something that we should wait? What would you do to kind of alleviate some of these doubts that's happening in the general population around this?
Well, I'm waiting for my mother to be eligible to be vaccinated, and I'm going to make sure that she is. I'm going to want everybody in my family to be vaccinated. Now, the question really is safety. We have at the moment only one safety signal that we know of, and that is the signal for anaphylaxis, which is something that we worry about for every vaccine. So in the case of the Pfizer and the Moderna vaccines, we are seeing an anaphylaxis signal that was not seen in the phase 3 trials. It's 1 in 150,000 vaccinated individuals for Pfizer, and 1 in 500,000 for the Moderna vaccine. We think it might be polyethylene glycol that's used to make the lipid nanoparticles. but it is something that is being seen in people largely who have a history of very severe allergies or anaphylaxis before, up to 70%. And it happens mostly in the first half hour after vaccination. So far, because immunization is taking place at sites that have been prepared, there have been no deaths due to anaphylaxis. In the review that was done by the Indian National AEFI Committee also, they found 2 cases of anaphylaxis that required hospitalizations, but those individuals have recovered. So anaphylaxis seems to be a clear safety signal with many classes of vaccines, both with the ones that we've used in India and the mRNA vaccines. So far, we don't have a safety signal with others. So on the grounds of safety, I don't think it's something where we need to keep monitoring, but we do not currently have a safety signal at this time.
Great. Thank you, Dr. Kang. So from vaccines, let's move a little bit over to health systems reform itself. Sujatha ji, you've been one of the most outspoken advocates for public health systems strengthening. In fact, in a recent article that you wrote, you said very presciently that health is a political question, and it's time that political leadership collectively agrees to set aside partisan acrimony and adopts a zero-tolerance policy to any laxity on matters of health. So here we are at the beginning of 2021, at the other side, hopefully, of an ongoing pandemic. In your opinion, have we gotten there? Has health finally made it through the fog of and centrally in the way that it should? Will this promote and argument health systems reforms? And in what way do you see that happening or not? So over to you.
Well, I think till now, health has been a very low priority, as you know. And we had to have a COVID pandemic to put it center stage and get noticed by our politicians at the federal and the state levels. So there has been, today, COVID has really made health a household concern with everyone. Everyone is looking at health and health systems and where we are. But I feel that much more could have been done, taking a cue, say, from the vaccine discussion we just had. I think there is a need to engage with people and involve the people much, much more by having greater transparency and the trust deficit being narrowed down much more. And what do I mean by that? Even in the case of vaccine, it was born of so much of controversy about co-vaccine and emergency approvals and so on, which led into people doubting whether it's okay to take a vaccine or not. When you approve under extraordinary conditions, being an extraordinary situation, the committee may have had very serious concerns, and I agree that they might have done the right to the people, that these are the conditions, this is a benefit cost. I mean, this is what we gain, we don't. So there's a sense of comfort in engaging the people and taking them into trust. So in saying that these are the, the ifs and the buts of the situation, and we've taken a call because of these compulsions, and this is a better option that we have chosen. So I think this kind of engagement of the people, decentralizing efforts to build the resilience and people's engagement with health systems is a great opportunity that COVID has really thrown. And so this top down from above, where you get formulas of what is to be done at the state level, that is something that I think we need to really give up and have a greater decentralized approaches to health systems. The one thing that has come out in this COVID pandemic is that it has shown up the glaring gaps in the health system as such. whether it is in terms of infrastructure at the grassroots level, at the district level where it matters, or in the urban cities. The fact that we don't have primary health care in urban cities, the fact that we didn't have really enough ventilators, enough ICUs, enough oxygen, beds that could provide oxygen support to patients. We didn't have PPEs, we didn't have gloves, we didn't have basic protective gear, which ought to have been a routinely available in our hospitals, be it in the public or the private sector. The fact that the lockdown meant even the private sector had to shut down their facilities, and the whole burden inequitably fell on the public facilities to take on. Now, these are all the issues that really came up, and I think it's a great learning exercise if we take the experience in a more positive manner, learn what were the gaps and try to bridge them now, because I strongly believe that this is not the last we've seen of COVID. I'm absolutely quite certain that in a couple of years, if not this year, we'll have another backlash of a viral epidemic, and we ought to be ready at all times to see that we don't suffer the way we did. I mean, we've done well in terms of gaining some element of self-sufficiency in the protective gear. We have done well the way we ramped up the beds, the way we got innovation going in being able to get ICU beds in shape and so on. But that's not enough, because we all know that it's not a question of creating a bed, it's a question of having skilled manpower who know how to incubate a patient, who know how to deal with ventilators and so on and so forth. So I think there's a huge agenda that the COVID has laid down, and it is now up to us to not go on and on about saying how well we have done, but to seriously look at the gaps and what lessons it has learned, so that we have a better strategy for health reform in the future years to come.
Great point, Sujatha ji. I mean, you talk about people-sensitive and citizen participatory planning and implementation for COVID, and how that could really have been much better planned, and we can see that. A quick follow-up question. Are there any examples of states that have done what you say needs to be done? I mean, would you say there are one or two states who are exemplars in the way they have managed some of this, especially with relation to decentralized decision making and better management capacity, especially within the public sector?
You know, I think there are beautiful examples. There are three of them that straight away need to be celebrated. One is the way Kerala handled it. Now, why is Kerala still stuck with so many cases? A different discussion. There are different reasons. But for a long time, they held the fort, having the lowest number of cases. And the way they did the test, treat, and case follow-up was just exemplary. The second example, which I was absolutely flawed, was the Dharavi example. When Dharavi said that they had found some COVID cases, believe me, my heart stood still, because it is so easy for it to have flared up. And the way they contained it, and the whole strategy that Bombay municipality, of course, under the guidance of their political and administrative leadership, but the way they worked it out was, I thought, fabulous. I mean, public-private partnerships, as well as ramping up the infrastructure, as well as getting all the people together. That kind of strategy, I think, I have never seen before, and that needs to be studied more closely to see what lessons it has. And the third quick example I can give you is Rajasthan, where again, they engaged people. So all these three examples, containment of the disease was only because of people's participation. And that's again the example we see in Ebola. Ebola, when it was contained in the three countries in 2014, Sierra Leone and Liberia and so on, it was not because of the hospitals, but because of the people engagement. That's what contained Ebola. So I keep coming back to the people, because that is one area I think we failed to do in this COVID management. I would have liked to have seen a much more aggressive promotion of getting civil society and people groups outside to take up management of the COVID epidemic as it was rolling out that we have. But I think there are several cases available which have shown that decentralized local participation and district administrations engaging with the people have been greatly successful.
Absolutely. So moving on from people's participations to PPPs, we'd like to talk a little bit about the role of the private sector in reacting to COVID. And Dr. Sibal, as you know, I mean, this is one pandemic where both the public and the private sector have actually managed to come together. The COVID has also resulted in a tremendous lowering of risk by the government. In many ways, they were willing to invest in innovations, especially digital innovations around COVID. And as those regulatory or barriers kind of lowered, it allowed the private sector to come forward, both in terms of innovation, as well as both engaging in really almost a whole of society kind of approach to dealing with COVID. But there's also a flip side to the argument, because in the early stages of the disease, we also saw the private sector struggle to deal with the disease. And as Sujatha ji said, you know, there's a lot of, it was the public sector that really took the brunt of managing the epidemic, whereas the private sector was still faltering in terms of pricing, in terms of ventilators, in terms of capacity gaps. So has COVID enabled the government to finally take risks around innovations with the private sector? And what kind of partnerships do you think are emerging? How should the division of roles and responsibilities between public and private be defined, both in terms of a pandemic, and where do you think this will pan out in the future?
Thank you very much to Inakshi and Priya for having me on this panel. So I'm going to start off with attempting to answer the first question that you posed to Dr. Kang and to Sujatha ji, which was like, what worked very well? So let me give you a private sector perspective on what worked very well. I think the first thing is that the public-private silos were finally broken. And it's about time, because we have to recognize that 62% of the health infrastructure in our country is private. Up to 70% of care is driven by the private sector. So, you know, we know that, we recognize this, and this was one opportunity where the public and the private sectors came together. The private sector was ready very early, and the private sector needed approvals from the government to step in, which happened. It varied at, you know, in different states, at what, you know, after how many weeks was the private sector roped in terms of either treatment or investigations, but it happened. You know, if today we've tested 200 million people, that's because while there are 1,214 COVID approved labs in the government sector, there are 1,155 in the private sector. We can't ignore the fact that the number of ICU beds in the private sector is nearly double at 60,000 compared to 35,000 in the public sector. And if we look at ventilator availability, it's close to 30,000 in the private sector and 17,000 in the public sector. So clearly, this battle could not have been waged without the public and the private sector coming together. So that was great. I think we learned how to adopt and adapt to treatment guidelines very quickly. Now we had an advantage of a few weeks, because we could see what was happening in Italy and Spain and Britain and the United States, and we knew that we'd have to prepare for what was going to hit us when the cases started to increase. So we started using the available guidelines that came out from the West and used that knowledge and adapted it to our system. So, you know, and there is a lot of knowledge out there available. And I did this search today on PubMed. There are more than 100,000 peer-reviewed papers on COVID. That works out to 248 papers a day. When I first started tracking this in March, they were like 5 papers a day. Now it's 248 papers. That's like more than 10 papers an hour. And the seamless information exchange between the public and the private sector, guidelines that were coming in from the government sector was making known. There was a fair amount of communication. To give you an example, we at Apollo changed our guidelines 34 times, including twice in a week when the recovery trial data came from England. And at midnight, we decided that from tomorrow morning, everyone who satisfied the criteria based on the UK trial would get steroids. So I think that was very positive. And I think that's something that we will be able to use in the future as well. I think communication was really effective in terms of being able to use technology. I mean, the fact of the matter is that our Arogya Setu had 5 crore downloads in 13 days, and that's a record in downloads. I mean, no app has ever got that kind of traction. Of course, with a population of 130 crores, there's always an opportunity to do more. We could have perhaps looked at things differently, but I think the use of technology was definitely something that went well. I think the fact that we got medication relatively early, the fact that we had access to remdesivir just after we started using steroids gave hope to people. The fact that we embarked on a very large plasma trial, in fact, the largest in the world, was very positive. Of course, now we know that the use of plasma is extremely limited, but at least it's based on science. We did, as a country, perform the largest trial on that. I think the interaction between the public and the private sector, if we look at the Covaxin collaboration, the collaboration between the National Institute of Virology and Bharat Biotech, I think that's a great example. We have more examples in the vaccine space. We have lots of examples in the diagnostic space where I think the public and the private sectors have worked together. I mean, for us at Apollo, we've done work with ICMR, with CCMB, with IGIB. And I think though there might have been glitches initially with COVID app, which was to be expected, I think now that we've vaccinated thousands of individuals at our system, I think COVID again shows the faith in digitalization in health. The fact that the telemedicine guidelines were issued very quickly, a huge relief to patients sitting in the Northeast who would normally travel to Chennai or to Delhi, for example, within our system for an opinion. So I think the adoption of technology has been wonderful. One great development, I think, from the Indian physician's perspective, is that we were able to break the geographical and the time zone barriers. We established the Global Indian Physician Collaborative Against COVID-19 in April. So we had physicians from API, which is the American Association, the British Association, the Canadian, the Australian, and GAPIO, which has membership in 53 countries, organize seminar after seminar. And that was very useful, whether it was about diagnostic, whether it was clinical presentation, it was about treatment, it was about debating vaccination. And we also discovered that there was a fair amount of burnout that was happening among the medical community. So we then requested spiritual leaders to talk about emotional well-being. We had His Holiness address the doctors. We had Sri Sri, we had Sister Shivani, we had Sadhguru. So lots of positives. The fact that we could this using technology, I think, is a huge gain. What could we have done better? Sujatha ji just gave 3 examples of states where things worked very well. And we do understand that health is a state subject and autonomy is very important. But think from a national point of view. Say, for example, we have hospitals in 16 states. So we had 16 different sets of rules that we had to look at virtually on a daily basis. So I had to, again, look at what would work in a particular state or not, and what would work in a particular district or not. So if perhaps when it's dealing with a pandemic, there could be some amount of standardization. For example, certain states allowed the private sector to test. Certain states allowed it much later. Certain states said, and certain districts said, you can only test if the patient like this. Some amount of standardization, uniformity would help. It would just for everyone. I think we have the stage right set for some of that when it comes to vaccination. Because again, as Dr. Kang was saying, if we are to get to 30 crores, because we can't ignore the fact that even 30 crores makes it just 3 crores less than the population of the United States and 3 crores more than the 4th most populated country in the world, Indonesia. So while we might say it's phase 1, but it's huge. And if we are to get to that level, it's going to have to be public-private sector, and we're going to have to ramp up, because otherwise we're not going to be able to vaccinate 130 crore people. So we're going to have to ramp up, because otherwise we're not going to be able to vaccinate 130 crore people. So I think to summarize, I think there are a huge number of lessons we've learned. I think we'll work better together in the true spirit of a partnership. And I think we've seen numerous examples of how this has worked, and I'm pretty certain that it will work. I think the government will have increasing confidence in that if we are to be able to meet the goals that the National Health Policy has, the 2017 policy, we are going to have to work together. There are just no... of course, with more money coming in, that's very welcome. I think we'd be able to do what we all in healthcare recognize spend more on public health infrastructure, on prevention, because at the end of the day, if we do not invest in prevention, we are never going to have enough capability, capacity to be able to provide secondary and tertiary and quaternary care that we will have to deal with.
So great points, Dr. Sibal. And you can see there are already new kinds of partnerships that are emerging between public sector and the private sector, especially in mixed health systems. And COVID has definitely thrown those into relief in a very. I'd like to actually flag a question that's come from one of the audience members, because this is going to be our next question that I was going to pose, and it's from Nargis Mystery. And basically, what she says that in the case of another pandemic, what do we do to avoid collateral damage to other diseases, as we saw in the first and second phase of the COVID lockdown in India? And as you know, disruption in general health services was a huge problem in pandemic response. And a lot of people failed to, acquire adequate healthcare. Epidemiologically as well, we are seeing a shift towards dealing with an NCD burden, and the number of people living with chronic diseases in India alone, I think is about 72.9 million right now. So I'd like to actually begin this conversation with Dr. Kang. How are we being epidemiologically prepared for the next pandemic, which is invariably NCDs? And how can we better manage this collateral damage going forward now that we have a handle on, where we are with vaccines, at least at this initial phase of the rollout?
I think there is an artificial divide in the kinds of health services that need to be delivered to people. I agree that we've had a lot of focus on communicable diseases. We've had a lot of national programs, many vertical national programs, one for AIDS, one for TB, one for, you name it. You've got all your neglected tropical diseases, what have you, all being addressed in individual silos, providing multiple sources of information and multiple opportunities for control mechanisms being developed. For NCDs, we've had a situation where the only thing that we've really looked at from a health system perspective has been maternal and child health. It has not been, the kinds of epidemics that we are seeing of increasing diabetes, cardiovascular disease, the increases in cancers. Those are, again, where they are dealt with individually, and in the case of cancer, through an infrastructure that does not take into account the rest of the country and the systems that prevail. So how do you create a system that does not put the disease at the center, but actually puts the person at the center of the delivery of healthcare? And we've never thought about it that way. We've always thought about it of, I am addressing this problem, not that I am addressing this person. And if you really want to be able to deliver preventive, promotive, therapeutic care, right? You have to be thinking about the person at their ages and stages. What are their needs and how do we deliver them? Now that requires a pretty hefty revamping of the system. And I'm not really sure that we are ready for that as yet. So what are the steps that we can take that will allow us to strengthen the delivery of different kinds of care that people need, even if we don't make the entire switch to putting people at the center of the services that we deliver? So there's I think one of the things that Ms. Rao said, which is about engaging with partners, engaging with all of society, I think is absolutely critical. And we need conversations about what we would like a health system to look like. When we have the privilege of private healthcare, we have the ability to construct for ourselves the health system that we want. And I think that inequity is only going to increase if we don't pay attention to it. If we begin to think about public-private partnerships, I think if we have a lens of how do we decrease inequity, that would be a way that I'd be comfortable. Otherwise, I get a little bit nervous about what these are really going to mean in terms of delivery of services to the people who need them the most.
Great. I think, Sujatha ji, you have a point. Please go ahead.
I was just thinking, what Nargis has said is absolutely true, that one of the issues that we don't talk about very much is the complete neglect of other diseases other than COVID. I mean, we managed COVID at a great cost. Almost everyone was only doing COVID and COVID and COVID. And recently, just yesterday, I saw some data from Kerala, which shows quite an increase in home deaths. And that is, reflective of the fact that it could be possible that many people like heart patients or people like TB patients or anyone who could not access healthcare and died at home. So this needs to be investigated much more. A lot of immunization sessions were postponed. TB treatment was postponed and disrupted, and so also other diseases. And the cost of that needs to be very, very honestly calibrated by us and not push it under the carpet. Because I think this virus, having been new, and the way it rolled out in the West alarmed us all. And I think there was initially a sense of panic, which, I mean, if I was secretary, I would have been in a panic too. So I don't think there's a question of blaming anyone in this. It was a situation like that. We knew very little about the virus, and every day was a learning experience for the doctors, for the people, and for everyone at large. So in that interregnum, whatever happened, the rest of the treatment for other diseases did suffer. So one lesson we have is that in future, if such a thing happens, instead of getting overwhelmed by it, I think it's time that we invest right now on public infrastructure for infectious diseases. That means, you remember how long it took for ICMR to recognize laboratories for testing. It took, good grief, it took 2 months for the government to allow laboratories to expand testing. So this kind of thing should not happen. I think we should have protocols, we should have disaster management plans or epidemic outbreak plans at a district level. So we know exactly which button to push and who to do what, so that we list out the essential services which will not be interrupted no matter what happens. And the new emergency that has arisen, we should be able to have other alternative cadres developed and trained to see that they handle it. So I think this balancing is tough. I'm not saying it's easy, but it can be done. I mean, having worked in the system for a long, I have the confidence to say that it can be done, provided we prepare our, I think at the district level, micro planning is engaged and done. In what happened, another mistake that happened here was that everything was very top down, and having declared it as a disaster management, much of the decision making and all and guidance went into the cabinet secretary and the Ministry of Home Affairs, who have no clue about health. And the Ministry of Health was, I mean, coordination was very good. I'm not suggesting that they did their best. So please don't take me wrong. But still, I feel the driver in the seat has to be the health ministry. And I strongly felt that, that the public health experts and the infrastructure for NCDC and all needs to be ramped up hugely. We need many more BSL labs. We need not just one NIV Pune, we need about 10 NIV Punas, and so on and so forth. So that was one takeaway that I got from here. And I think that it is very valid what Nargis has just raised. It's an absolutely a fact that other diseases did suffer, particularly TB.
Great point there. And also the need to move down from this top-down response to a more lateral response where decision making can also be decentralized at the local level, which is very important. We have another interesting question from the audience. Sebin Abraham asks a question on, while innovations in healthcare technology is to be lauded, how do we address the concerns about privacy breach and data theft? And this is another, interesting question as we begin to talk about accelerating digitalization. And one thing that we've seen that the COVID pandemic really boost in our country is the ability to invest in surveillance. So suddenly there were a lot of surveillance apps. There was a lot of surveillance going on both at the central and the state level. But at the end of the day, where does this data, how does it trickle down? Where is the level of transparency? And if private players are going to be part of an embedded digitalized health system, will they be more willing to share health data than they are today? So I'd like to start with Dr. Sibal. What are your thoughts on the role of data privacy and transparency in enabling health systems to function more efficiently, at least from a private sector perspective? Would you be willing to be regulated to this effect?
Well, I think every citizen, every global citizen is concerned about data. They really are. What is private, what is not private, who has access to my records is a very genuine concern that everyone has. They have it in the US, they have it in India. And I'm really happy that we actually are getting a framework with the National Digital Health Mission. So, we are moving in that direction. We need to define, just like they have in the US, what are the privacy regulations. And I'm pretty certain that it will be welcomed by everyone. And it's not a question of public or private sector. Any healthcare provider will work within the rules and the regulations that are established. And I think this is a very welcome step, and it's something that's happened at the right time. And from what we've heard from the panelists and also from our participants is, talk about NCDs. You alluded to that, but at this point in time, if you have to tease out data, it's very hard to do that. When you look at subgroups, you look at comorbidities, you look at the complexities, and you look at how is it that we can best prevent progression, say in diabetes, which we know is a progressive condition. I think digitalization is really going to give us access to be able to plan things on a state level, district level, or a national level. So I think digitalization is crucial if we really are to move forward and achieve better health for everyone. And I think everyone who is going to be involved in healthcare, public, private, charitable, will comply with all the rules and regulations that are made. And I'm so glad that we have a framework that is going to be created.
Great. Sujatha ji, will the regulation and management of health data change significantly now as a result of COVID? What are your thoughts? And do you think the government has the management capacity to deal with data at this volume?
I think government by itself may not, but now that they brought a law, they'll have to get more into digitization. They'll have to get more into using digital platforms to collect and collate the data. But I do think that that the ministry and the government must invest a lot more on having biostatisticians and skilled people at right down at the district level. There's nothing at the district level. So it's not enough just to have one or two in the Ministry of Health. That's a weak point again. So I think data management is so key and fundamental to managing a pandemic. I mean, for polio, for example, we had almost about 200 people working round the clock just on data and data monitoring. And I don't know how many were here now. So, this is something that right down to the district level, we need to have good data management and people skilled in it, biostatisticians mainly, and epidemiologists. So as of now, it's the digitization is going to be a great help, and government by itself doesn't have the capacity. They have to invest on it. They certainly do.
Great. So from digitization, we'll just move on to this whole question of intersectoral collaboration, which Dr. Kang talked about. Bina Verghese from the audience poses a question that there's a need for more intersectoral discussions, not only among the state, but also with the private sector, so that a lot of the stigma that we initially saw through the blocking, barricading of houses and streets, the implications or the command and control way in which lockdowns were established, could actually have had a more nuanced and a sensitive way of being done. Intersectoral action also means that many aspects of health systems can actually come together to create those valuable reference mechanisms that we really need and we lack in our current health systems today. So Dr. Kang, could you actually comment on that? Because I know that this is one of the things that you feel quite strongly about.
So perhaps we could argue that the government in its current budget is understanding the importance of intersectorality because they've put water and sanitation under the health budget. And I hope that if the recognition is that these are important, there will be many other areas that will also be brought under health and increase allocations that may be health adjacent, health relevant. But in terms of what's really been happening on the ground, so I'll give you a practical example. My team is doing a collection of serum samples for typhoid at the moment. And we thought, oh, this is a good opportunity. Why don't we do a sero survey for COVID-19 antibodies as well? You mentioned COVID-19 testing of any kind, and no one is willing to give you a sample. No one is willing to participate. No one is willing to talk. We run clinics in slum areas that were considered containment zones. Nobody is reporting fevers. Nobody is reporting respiratory infections. Okay, why is that? Because they were treated so badly that they now don't trust anybody. And we have built trust with them over a period of 20 years and lost it because they view this as something that the health system did to them. The fact that it was other arms of the government and not my group as researchers that have been working with the community is not a distinction that is recognized or easily recognized. You have to do a lot of convincing to build that trust back. So I think if the government wants for people to be partners in implementing what they are recommending, building that trust is absolutely essential. And it cannot be one arm of the government or one part of society alone that can build that trust. It has to be everybody together. And I think the one thing that we see with the Disaster Management Act, with the top-down approach, I get the sense that we don't necessarily respect people in the way that we think that they should be respected. You know, your position in society should not define how you are treated by arms of the government or arms of the private sector. Enough said.
Great points. So moving on to, one other thing that has actually been echoing in our question answer page also is that, healthcare at the grassroots level. So we have Shamdas Banerjee, who talked about preventive care using information technology and developing a robust health information system. There's a talk about educating people on public health to enable them to adapt to good health practices. And a question from Daniel David, who says that, is there enough political will to improve the health system, public health of the nation? And is there enough space for public health specialists to work directly with the authorities? So a lot of this kind of distills down to, I think, a fundamental need to invest in primary healthcare. I think if it's one thing that COVID has shown us, that you can only address specialized care beyond a point. But if you do not have that fundamental investment in primary health, both in terms of infrastructure, you cannot really get to where you need to go as a health system. Sujatha ji, you've been a firm advocate for additional investments in primary healthcare. Where do you see this going as a result of COVID? Do you think we will get to where we are? Have we gotten to where we are? And where do you see some of those gaps being bridged?
Well, one of the components of Ayushman Bharat was to strengthen sub-centers, as they call them, wellness clinics. I think that was an excellent initiative, long overdue. And it was a part of the report that I was also associated with of 2014, when we said health and wellness, family health clinics, taking the Brazil's family health clinic approach to primary care was adapted, and this group worked out. And I'm glad that it saw its actualization subsequently. And they do have a trained BSc nurse as the community health officer at the sub-center level. So it's a good initiative, but it takes a lot of money. And that's where my quarrel with the government starts, that they don't give us enough budgets. In 1819, we spent 0.93% of GDP on health. COVID was an extraordinary situation. It was a moment. It was a historical moment, something like what UK faced in Second World War, when everything got devastated. And in that devastation, UK announced NHS. That's how NHS was born. This is a similar moment for us. I mean, economy couldn't have been worse. Every section of society has been impacted. And this was a time when I was hoping for a great health budget, where a strong political statement would be made by seeing that we reach at least 2% of GDP on health, or reprioritize our health investments in such a manner that it's a strong assertion of the fact that we need to invest on building up public health. And that has not happened, because if you minus the amount that they had to spend for COVID emergencies, like the PPE kits and masks and so on, the increase in the health budget, according to the traditional health budget, has only been 7.5%, which, if is really nothing, really. Now, the other three components, 35,000 crores for vaccines, which will be on actuals as and when it rolls out. The 68,000 crores that has been promised for the new scheme for Prime Minister's Atmanirbhar Swasthya Bharat Yojana, that has not been budgeted in this budget. It might come as a supplementary budget, which normally supplementary budgets come out in October or so. So that means nothing will be done right now. And the Finance Commission gave some 35,000 crores for public health infrastructure, which is a great step. But then that hasn't been agreed to by government. So what I'm saying is that despite this extraordinarily traumatic experience we've gone through, still I find that the government commitment in terms of giving resources for health. Of course, I'm grateful that given the economic compulsions, at least we have not faced a cut like nutrition has. That's been a 22% cut. We have not faced cuts. Education has faced a huge cut. But there should have been a much huger expenditure and investment on quickly ramping up the public health, whether it's laboratories, district hospitals with proper ICU and oxygen support systems, human resources to be ramped up much faster, and speeding up the wellness clinics in the primary care. Just these 3-4 nodes of the health system, if we had only ramped it up, we don't have much time, I would have been much happier. So are we there on primary care? Not really, because there are 23%, about almost 25% on an average shortages still in terms of sub-centers availability and primary healthcare centers availability. This is, I'm talking after 72 years of independence. This is not acceptable.
Yes,
yeah, can I come?
Yes, please come in, Anupamji. Yes.
So I was reading the wonderful note Dr. Banerjee wrote, and I just wanted to applaud him for his thinking about primary care and how is it that we can improve. Last mile delivery. So I just wanted to share, because we have participants from all over the world, just give a few examples of what is working very well. For example, in Jharkhand, it's again a PPP, and we've been managing 100 centers. We've treated 4.43 lakh people, and what we found, and which is very gratifying, is that only 11% needed a specialist referral, which means that the vast majority would have, say, traveled to Ranchi to be told that you needn't have come. This could be managed locally. Similar example in UP, where we run 120 centers. In Andhra Pradesh, where we've been doing this for a while, and we've treated 1.2 crore people. Again, testing at the urban health center and giving the kind of information that we need to improve health is working. I mean, with ophthalmology, for example, more than 3 lakh fundus exams have been done in the villages, and more than 1 million spectacles have been provided. So, I mean, there are examples within the country where India is a very large country. And when we look at it as a whole, some of this good work in different states really needs to be, to go to other districts. I just want to give 2 more examples on how Sujatha just mentioned about the gaps that we have. See, for example, we are never going to have enough intensivists in our country. So why can't we use EICUs? We saw that with COVID. We managed 150 beds using an EICU module where one intensivist was managing the beds across 8 states in a shift, because you're never going to have enough intensivists. We, through artificial intelligence and machine learning, are able to report chest x-rays without a radiologist in villages now. To look at a WhatsApp image and say whether you need a thrombolysis after a stroke or not. So, we have to be able to use this kind of technology, because given no matter we're producing 70,000 doctors, and 10,000 go abroad for training to Russia and China and come back, we're never going to have the kind of numbers that we really would like to have. So why not invest in technology, because there's a lot available. And I think some of the discussion, the narrative does need to move towards using technology. It's not just about digitization, but it's about using technology, whether it's teleradiology or telepathology, and that's something that's here to stay. It's a question of how quickly are we going to take it pan-India.
Absolutely.
I would like to second that.
Yes. Any thoughts on that?
I would like to second that. Okay. Yeah, I just wanted to, I said that's a great point, and I would like to second that. Even in Andhra, they very quickly, in fact, in the month of April itself, they took up telemedicine as a way of, being able to reach out to patients, and they had a call center, and it worked exceedingly well, because people were afraid to come to the hospitals. So they did decongest hospitals and hospital visits by giving care, and Apollo came up with a very good home care module for those having minor symptoms of COVID and home treatment. So I think these are all great lessons which we have an opportunity now to multiply. But the fact, yes, that primary care has to be the focus, I think it needs no reiteration. It's absolutely important, because all the evidence around the globe has shown that almost 30 to 40% of hospitalization, cardiac cases, cancer cases can all be averted if we had good, solid primary care.
Great points. There's a question for Dr. Sibal from Marcel Fleur. In fact, he comments on the fact that you had indicated cross-border information sharing worldwide, and you had said that last year it was tremendous. And he says, however, cold water fear for real-time sharing of data, pathogens, either within knowledge institutes in India or within the government, could stand in the way for more structural cooperation. What is your take on that? So do you think that cross-border sharing has improved, and where do you think that we could take some of these lessons learned?
Well, that's a great point you make. And obviously, historically, there has always been this concern about data sharing. And that's been a problem. But I think what we have seen here is that the ice is broken. And I think the individual to individual connections that have been established are going to open the way for more formal collaborations. And I think we're going to see a lot of them. We're already seeing that with the development of kits. We are seeing that with the kind of trials that we've seen for therapy for COVID. And more and more trials are coming on with more and more agents being studied. We've seen that with vaccines. We've seen the kind of collaboration that would normally take years has kind of materialized in weeks. And I personally feel that that's really going to be very and it's solid. I mean, across the, because once you have a man-to-man contact, and you are able, as Gagandeep ji said, it takes. So hopefully we are in that zone where the trust building has started. So I think it's only going to be positive.
Great. Thanks, Dr. Sibal. We actually are joined by Dr. Arora. So welcome, Dr. Arora. You are last, but certainly not the least. And so thank you for making the time to hop off your call with WHO. Hope it went well and join us over here. So I thought that, while we are at the thick of discussions, especially talking about cross-border knowledge sharing, cross-pollination of data, the efficacy of vaccine and the investment in health. You had made an interesting point the other day when we were talking about how India could also use this opportunity to invest in its role in the global health arena, especially in relation to vaccine deployment, or what you call as global vaccine diplomacy. I thought it made a very strong point. And in a time where there is geopolitical tensions, not only around health systems, but also how individual countries are managing the pandemic, this will become a key point in India's own role as a regional player in health systems reform. It would be great to get your thoughts on that going forward.
Thank you, Priya. My apologies for joining late. The point about this health diplomacy, and Sujatha ji is there. She knows very well. And over last, I think, 2 decades, we have developed our prowess, particularly in manufacturing pharmaceuticals, and last 8 or 10 years in vaccines. And as a result, even in case of pandemic or dire situations, we have seen in otherwise also natural disasters, India has come forward and sharing its at least medical supplies and reliefs to our neighboring countries. If you remember the massive earthquake we had in Nepal in 2015. And and this is not only on a humanitarian component, but I think on a diplomatic front also, it's extremely useful. We know that Indian vaccine manufacturers have now adopted global standards. Most of our vaccines are WHO pre-qualified, and the cost is much lower. In fact, the Indian manufacturers have pushed the global players to bring down their prices. So the key beneficiary is low and middle income countries. Take, for example, pentavalent vaccine and hepatitis B vaccine, which used to be so expensive, and we have brought down level to less than 10 cents per dose. So these are areas where our poor friends or low and middle income countries have really appreciated that, and they know that it helps. And during the pandemic, I think we have shown how we can become an important player. Now, in the COVAX facility, which WHO has established for distributing 2 billion worth of doses across the countries, and focuses on Gavi supported countries or so. And India is considered a major player in that. And this has brought in, I think, a lot of goodwill. We have to and one of the priority issues here is that quality is very important. We need to have the world class, and we have to use cutting edge technology, and the quality of the product has to be good, so that we continue to enjoy this goodwill, but also build on this. And I do not know how many of our viewers know about it, that WHO has a whole division of health diplomacy. And in certain areas, in fact, health diplomacy works better than supporting the other country or friendly country with arms and weapons and ammunition. So I think this is a good area. India is trying to enter into it, and with quite a reasonable success, I would say.
Priya, there's
Yes.
another health diplomacy, if I might come in, which is providing tertiary and quaternary care. Just 3 days ago, we got a plane full from Myanmar. We chartered an aircraft from Myanmar for patients who've been waiting for 6 months to come over. So, fact of the matter is that India sees patients from 120 countries for treatment.
Yeah.
You're absolutely right, Dr. Sibal, that today I understand that the Indian market for this care, tertiary care and quaternary care, means state of art, almost $5 billion is I think it is between $5 to $7 billion annual market for us. So it has given revenue also, and besides the goodwill we are talking about.
Absolutely. We have a couple more questions coming in. Actually, this is something that I thought I could flag. Two more questions, actually. One from Dr. Zara. And I'd like to address this to Dr. Kang. She talks about, she says, could you talk about the impending mental health epidemic that this lockdown has revealed? And this is something that we, as public health practitioners, have not really addressed. One thing that the pandemic really brought about was fear. Another thing a lot of the lockdowns did was to create a sense of isolation, and this compounded with fear, created yet another collateral damage or health systems challenge, making COVID more a syndemic, where it interfaces with several health system challenges. So what are your thoughts on addressing some of these issues? How could we potentially channelize some of the resources or expertise, and what do you think we have learned from this in terms of addressing mental health issues?
So I think if we think about what's happened in the world, for even the most resilient person, it has been quite a challenge to undertake the isolation, which you mentioned, but also what is happening in terms of the loss of economic opportunities, lack of clarity on what the future looks like for large sections of the population. So we tend to think about mental well-being and mental health as something that applies to our stratum of society. And what we don't realize is this is something that affects everybody. We've done surveys looking at mental health where we can identify clear issues in up to 10% of the populations that we work with that are the underprivileged. And the scale of the problem is bad at the best of times, and these are not the best of times. So what is it that we can do to address this? Formal mental health services are not enough. We don't have enough professionals that are trained that can help with this. So thinking through what public health, psychiatry, what public mental health efforts can be put into place is something that I think is a real and urgent need. And yet it is something that we don't recognize, don't prepare for, because it's not like a physical ailment. So when you don't have something that is an organic dysfunction or something that is visible to you, it's very, very difficult to think about how we address this. And the problem for me really is not so much about how much of a problem it is today and how much of an unaddressed problem it is today, but also what are the consequences of this going to be on society? What's happening with students? in schools, in colleges? What is this going to mean to the people that they will grow up to be? So just the scale of it is something that I think should terrify us all.
Dr. Sibal, do you think that the private sector is contributing to helping elevate some of these issues around mental health? I mean, is there a role that the private sector will increasingly play in primary healthcare with a shift away from investments only in hospitalization, but also towards more preventive, a more preventive focus to healthcare? Will there be an investment towards that? Do you have any thoughts?
The answer, Priya, to all three is a big yes, a resounding yes. I think the realization has been there for a while that we need to empower individuals to focus on prevention, and using a lot of. I mean, I'll just give you an example. We've just reviewed our data using AI for all the preventive health checks that we've done, 20 million of them. And we are developing a mechanism by which we can actually get individuals into a proactive 3-year program and actually look at goals in how am I going to improve my glycosylated hemoglobin if I'm a diabetic? What realistic goals? Throw in the counselors, look at nutrition, look at exercise, look at holistic care. Clearly, mental health is an issue that has become center stage for our society now. So we've been working with corporates and we've been working with the HR departments, many companies, in providing counseling in terms of being able to cope with having someone who's a professional go through what an individual is experiencing and actually give appropriate advice. So I think you're going to see a definite shift in the way we move forward. One of the things that is becoming very clear is that you really need to work towards minimizing hospitalization. Just to give you an example, and COVID has taught us this, we're actually sending home knee replacement patients after 24 hours. We actually did a hip replacement and sent the individual back home the same day, with rehabilitation happening at home. So the idea really is to minimize the average length of stay. So it's not going to be adding more quaternary beds. It's going to be about optimally utilizing the infrastructure and using resources in preventing patients from coming into hospital, and when they do, sending them back home quickly.
Priya, if I can come in.
Yes.
The pandemic has shown us the major gaps in the implementation of the National Mental Health Program. It has been limping and very little. But two issues which we have learned is that there is need for task transfer. We don't have psychiatrists all over, or even trained clinicians or primary care physicians. So this lot of mental health issues can be taken up at health worker, and it was mentioned, health and wellness centers. Some of this talking, counseling, and which is near to the homes by trained health providers. So that is an important realization during this pandemic, because mental health has been a huge issue, along with stigma associated with Gagandeep was mentioning that people won't come forward. So these issues require talking, counseling, and clearly this does not require a psychiatrist. But this task transfer this is a big realization, and through this medium, I would like to communicate that we need to take it up on a war footing, because this issue is beyond a pandemic. We know almost how much 10% of our adult population have either depression or anxiety, and this is a huge issue, and it cannot be managed even at primary care hospitals. It has to be at sub-center and healthcare workers.
Good points. We have a question from Sundar Hemrajani for Dr. Kang. I think you mentioned this earlier on in the discussion, but really, again, it's a question around vaccine development. And he basically says it seems to be like a work in progress. And of course, here he addresses the AstraZeneca vaccine doesn't work in the South African context. should one wait for some time before taking the jab? So what would your advice be? Should he go with the jab or not?
In India, take the vaccine. We don't have surveillance that tells us that we have the South African variant in any significant numbers in the country. In South Africa, where the vaccine was shown not to work in a subset of young people with mild or moderate disease, that variant is 90% of the strains that are being detected. The situation with variants is very different in India. So therefore, taking the vaccine is advisable. Does this mean that we will never need to take any other vaccines, right? Are we taking 2 doses and going to be done with this forever? We don't know how long the vaccines will protect for, even against the strains that we have. We don't know if the vaccine will protect against new variants that will come. What we do know is against the viruses that are currently circulating in this country, this vaccine is likely to give us protection. So, and the immune system is a fantastic thing. I think you can rely on it to give you some protection now, and there will be more vaccines and more data in the future that we will be able to optimize to deliver the best possible protection to as many people as possible for as long as possible. The data we have today is limited, but it increases every day.
I would like to add here that this is the time for maximum number of Indians getting immunized before the spread of mutants takes place. Because even if it has some partial impact, but if there are large number who are immunized, the spread is likely to be decelerated or slowed down. So even if we are worried, everybody is hearing about South African strain, but since it is not so widespread, this is the time we should rapidly take, and that is the guidance from other European countries also, that whatever is available at the moment, we should rapidly take it up, which will help. It is not going to be useless. It will help, certainly.
On that note, Dr. Arora, there's another question from Marcel. He says that Indian vaccine producers have managed to push down the prices on a global scale. And now many of the European countries also have extensive immunization programs supplied for by non-Indian companies, whereas Indian producers seem to keep on walking around the pool. Will there be a moment where they'll jump in, and what is required for that, apart from market authorization? So that's his question.
So if I understand what I'm, is it that when will Indian vaccines be available in the open market for rest of the world? And that is what I was trying to say, that through COVAX facility, the Indian vaccines will be available in quite a substantial volume for rest of the world. So, and it is much cheaper. The COVAX price for low and middle income countries is $3, but for the other countries, some negotiations will take place, but certainly it will be much cheaper as compared to the vaccines manufactured in the high income countries. So, as I understand, the capacity of Serum Institute and some of the other new vaccine manufacturers is going to be pretty huge. India may be able to manufacture up to 2 to 3 billion doses per year, the way I see the capacities as the new vaccines come up annually.
Thank you, Dr. Arora. We are almost out of time. I think I'll take one more question from the audience before posing a final question to all panelists. This one is from Rajiv Kaul, and I'll pose it to Dr. Sujatha Rao. He says that in the future, India should bring pandemic management under the National Disaster Management Agency, which was formed in 2005. They've done excellent work in the cases of floods and earthquakes. And it covers several areas. Handling of health pandemics also needs to be added to this. What are your thoughts?
I'm not so sure, because I think health is a very specialized field. It requires domain knowledge about it. It's, if you kind of put it under disaster management run by the Ministry of Home Affairs, then you'll have the kind of pandemic management that we had, law and order. It is the police forces and using it more, enforcing the guidelines more as a law and order rather than as a public health problem. So I think pandemics have to be managed as a public health emergency by people who are trained in public health and by the health system, which then has to be supported politically to be able to coordinate with all the other related departments and give that one approach to the entire fight. But I don't believe that it should be under the National Disaster Management, because what I saw of it in this time, I had a lot of concerns. So I would much rather have the Health Ministry piloting it. It's not a question of why not. It is a question of who has the domain knowledge. And I do sincerely believe that public health cannot be controlled or managed by government fiats. It cannot be controlled and managed as a law and order problem, and it cannot be controlled and managed from top down. It requires a huge amount of horizontal and decentralized approaches, which only a good health system can give.
Thanks, Sujatha ji. I'd like to kind of end with one final question, actually two. And the first can be a yes or no. The first one is, will new kinds of public-private partnerships become the norm in the healthcare ecosystem of India today? Will it augment and further health system reform? And if you had a crystal ball, and given the current Indian health budget, where there is a 137% hike in the health budget, and of that budget, 89% of a lot of the extra funding has been allocated to COVID-19 management, what are the areas that you would prioritize going forward? So we'll start in no particular order. Let's start with Dr. Arora and move on from there.
Thank you very much. This is a very good concluding comment you're asking for. And the whole issue is we are repeatedly discussing how we can bring in resilience into the system. And the pandemic has also shown us that public and private system can work together.
Dr. Arora, I think you've muted.
Right willingness, if we have options available and people can come together. So that is about private-public. I think the confidence of the system has increased on private system. And number two, the resilience on the ground, that how along with pandemic, the other primary healthcare systems services can continue, or what needs to be done for that. We need to learn some of those lessons and build on our future on that experiences.
Great. Dr. Kang.
In healthcare, there are two things that I think are really important. One, which we've spoken about before, is trust. And the second is quality. And I had mentioned equity before, but I think you will have equity when you have quality in your healthcare system, because you will have a system that everyone will want to access. It's a distant dream at the moment. And I hope that it comes to some sort of fruition in my lifetime.
Dr. Rao?
But I think in PPP, first of all, there is no option but to work with the private sector. I think it's no longer a question of they or us. It is public and private have to work together, and so that's something that is a given. But even though we do appreciate, and I think a lot of examples were given where the public and the private sector did work very creatively and very well in managing the COVID. But there were, let's not also push under the carpet a lot of examples that came up where the people were spending huge amounts in getting treatment in the private hospitals, and the amount of money they were spending on diagnostics and so on. So I think in whether it's in management of pandemics or whether it is a regular places, I think there has to be something to do with pricing and to see that people don't get impoverished while seeking private care. I think that's something very critical on which the government needs to work on. And one more point I would like to make is there was no 137% increase in the health budget. That included water, sanitation, nutrition, which have their own budgets. The point is social determinants have a direct impact on health outcomes. I'm not saying no. But then for that matter, the whole agriculture ministry budget also should be shown, because if you don't have food, you'd be dead. Or air pollution, contaminated air causes almost 1 million deaths in our country every year. So that also should be shown. So, when we try to compare health previous to now, we look at health budgets, doctor, drugs and medicines and technologies and hospitals. So to that extent, as I said earlier, the increase in the budget has been very modest. And but then I hope as the economy improves, much more investment will be made in improving and ramping up our health infrastructure. It desperately needs that kind of support.
And finally, Dr. Sibal.
For the first question, the answer is that we will find new ways of working together. As Sujatha ji said, it's all about coming together. There'll be different formulations, there'll be different ways of doing it, but we will, I think, work together. Private-public partnership is, I think, going to be the way forward. If one had a crystal ball, the National Health Policy 2017 talked about increasing the government spend to 2.5% of the GDP by 2025. Can we please bring that forward? Why do we have to wait for 4 years to reach that figure? I think COVID has really shown that we need more money. We've put in 35,000 crores for the COVID vaccine, which is roughly 270 rupees per person for 130 crore people. If we do need the vaccine again, which we might next year, we don't really have to allocate so much money, but can that 35,000 please remain with the health ministry? Let that 35,000 not go away from the kitty. And the third is, while we invest more in primary healthcare, I think we need to invest in education. We have the National Medical Commission. We need to invest more in training better doctors. We have the National Commission for Allied Healthcare Professionals that is in part, hopefully will get passed. And then we have the National Commission for Nursing coming up. We really do need to look at training allied healthcare professionals and nurses so that there are greater opportunities, and we produce nurses who can function and meet the needs of citizens in 2025.
Priya, I will break the law and again come back and make only one comment. And notwithstanding all the limitations and the comments of all the panelists, I would say one point. Pandemic has brought health into political focus. And that was the first part of the budget which was presented. I think this is a great step forward. So while a lot more needs to be done, but this point needs to be noted that health has attained the political eye, number one, and also this awareness that convergence is required. So whether we are talking about water, sanitation, etc., that unless sectors come together, health alone cannot take care of the health of this country.
Great. Thanks, Dr. Arora. So a couple of really quick takeaways as we leave you all. We need to fast track political reforms in health like never before. We need to build a data culture that is both useful and can build efficiency and affordability across the health sector. We need to engage communities like never before. We need to engage private health sector services and innovations in new kinds of partnerships. We need to plan together for associated health impacts. And last but not ever the least, we need to invest in public health, not only fiscally, but socially and economically. And therein lies a future for a bright and better 2021. With that, I'd like to thank Dr. Gagandeep Kang, Madam Sujatha Rao, Dr. Arora, Dr. Sibal, and the Asia Society for this wonderful opportunity and discussion. Thank you very much and good night.